I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. So good evening, Jam. Here we are, another late night Myeloma Minutes session. What have we got in store today for our listeners?
A really nice and important topic, Sally, blood clots. So we're going to talk about blood clots and myeloma. Blood clearly is what we're here to talk about, and we are blood doctors by specialism. Over tens of thousands of years, our blood has evolved to clot when we need it to, just stating the, maybe blindingly obvious, but when we bleed, we don't want to bleed out. And our blood has these checks and balances to keep it flowing when it needs to, but also stopping when it needs to. So, forming blood clots or plugs. Of course, the system doesn't always work, and sometimes you can get clots in the wrong places that can make people really sick, can even be fatal.
I wonder how many of our listeners will think this is a bit random because, I haven't had a blood clot. Why is it a relatively niche podcast talking about something which actually doesn't necessarily impact on me or their loved ones? But I think it's fair to say that almost every myeloma doctor or every person being treated for myeloma, the thought would have gone through their team's head, is this person at risk of a blood clot and what can I do about it? And that's because myeloma in itself, the diagnosis of myeloma does increase your risk a bit. And we are frequently dishing out medication to minimise the risk of a blood clot. And I guess we'll explore why that's quite so important and what those medications are and what they mean for our patients.
Indeed. And there's lots of medical terms bandied around about all sorts of different types of clots that cause different sorts of problems. Deep venous thrombosis, pulmonary embolism, even conditions like heart attacks and certain types of strokes are caused by blood clots. But to break it down, Sally, very, very broadly, you can either have blood clots in your veins, so the venous system, which broadly means these blood vessels that take blood back towards the heart, or you can have blood clots in arteries. So these are the blood vessels that broadly, move blood away from the heart. And that's blood that has oxygen in it. We call it oxygenated blood. Now, the kind of clots that we are normally thinking about as myeloma doctors are venous clots, but arterial clots do need to come into our thinking and understanding as well.
Yeah, I think it's a really actually is an important distinction, isn't it? The difference between the two, because your typical arterial clot, as you said, is your heart attack, it's your stroke, it's those blood clots which are very common in day-to-day language. And I think the venous side of things is more common in myeloma. Of course, myeloma patients can still unfortunately suffer from the arterial clots, but they're the ones that can affect myeloma patients because that's where the risk is increased by the greatest amount in our myeloma patients, be that because of their disease or their treatment and so on and so forth. When you're having a heart attack, the typical sort of movie version of a heart attack is, oh my God, I've got pain in my chest. And, if you were to look at it from a movie perspective, someone will then keel over or you're having a stroke and it becomes very obvious. And they're the arterial clots, but the venous clots are sometimes a bit more subtle, and that's a really important difference. It can take a while to figure out what's going on with them, I would say.
Indeed, although unfortunately they can also be rapidly fatal and make people very sick if the clot goes to the lungs, the so-called pulmonary embolism. So Sal, if we get back to the clotting and the flowing of blood without getting too sort of technically physiological, it's important that our blood can clot so we don't bleed out. And it's not just external bleeding, it's internal bleeding. But because of the so many different types of illnesses that people have, this kind of balance between blood being too thin or too thick is normally kept within really stable parameters. And it's extremely clever and it's evolved over thousands of years. So your body knows, I need to keep blood flowing throughout the body so, oxygen and nutrients can get to all our cells. But if I'm damaged, I've got all these systems in place to just change the balance of what's happening, switch on some signals that lead to various proteins and these things called platelets that we've talked about in one of our previous episodes cause these plugs. And if that balance is affected by a variety of different disease processes, you can end up with clots in the wrong place. If you're thinking about any sort of system where you have vessels, I don't know why toilet came into my mind, but I was about to talk about a blocked toilet. But essentially, if you have blockages in the wrong places, problems can occur. This is why I didn't become a scientist or physiologist. Essentially, it's a very poor description of basically saying our body's so good at keeping balance, but so many diseases mean that you can end up leading to problems where your blood is more likely to clot, and that can cause issues. Now, of course, the opposite is also possible, but we're talking about, clots today.
I think, God, both you and I can still remember the trauma of doing our final exams in clotting. Oh, my word. How hard is this as a subject? Because it's so incredibly complicated. And, it's really important that specialist doctors understand all that. But I think for a myeloma patient coming to clinic, we can simplify it quite a lot.
Totally.
And think about what really, the things that we're looking at in clinic, like, is your platelet count high enough or too low? Are your kidneys working properly? What's your myeloma up to? And they give us really big clues in the clinic setting as to this person is more likely to be at risk of a blood clot, or the other end of the spectrum, actually this person might be at risk of bleeding because their platelets are low and we've got them on a blood thinner. So we can simplify it, but it's a whole other huge specialist area in and of itself.
Yeah, and broadly speaking, if we just talk about venous clots, so deep venous thrombosis and pulmonary embolism, cancer in itself is a big risk factor for getting these things. And that's unfortunately any cancer. And there's a number of reasons for that, but inflammation is part of that. And outside of cancer, number of risk factors associated with blood clots: smoking, being obese, being very sedentary, post-operative, such a huge area that so much work has been done to minimize the impact of that because people are often very immobile after operations. So, of course, these factors can apply to our patients as well. But Sal, if you think about someone who comes to see you for the first time with myeloma, you're sort of dynamically assessing their potential risk of having clots, as they come through the door as part of an initial assessment, right? And that's partly because of the disease and partly because of some of the medication or chemo you're going to give them as well, right?
Yeah, definitely. It's one of those things actually which you're sort of trained to do. And again, if you were to break it down into how one may have learned it, how we may have learned it at medical school, you're looking at the patient and have they had blood clots before? Are they on blood thinners? Do they have those risk factors you've spoken about? Their situation, are they mobile? Are they immobile? Have they just been poorly in hospital with infection and operation, like you said? Their myeloma, if your myeloma is more active, you're more prone to blood clots because of the nature of the myeloma. And to put it very crudely, the way that the proteins in the blood could just make the blood somewhat thicker. We've spoken about that on previous podcasts, a sort of hyperviscosity syndrome. And then you chuck in the medication on top of that as well. And there are particular classes of medication, particularly that class of drugs that we call the immunomodulatory drugs. So that's lenalidomide, thalidomide, pomalidomide, for example, that can increase your risk of blood clots, as can steroids. So there's a whole load of things which are kind of swilling around in the mix there to make you think, okay, you do this sort of almost automatic checklist in your head. Yeah. Where is this person on this risk scale? And if you think their risk is beyond a tipping point, you think, okay, I need to do something about it. I need to prevent that clot and start them on blood thinners.
Pain is also another one. People often have uncontrolled pain at the beginning, just linking to the last pod that we did. If you're in pain, you don't want to move as much. And sometimes that spinal pain can lead to people not moving. So unfortunately, it can be a real perfect storm of poor mobility because of back pain, for example, having active cancer, having high levels of these paraproteins in the blood, and then potentially considering the initiation of combination chemotherapy, including immunomodulatory agents.
Definitely. And that pain, I'm really glad you mentioned that, Jam. That's another really good reason, actually. We didn't really speak about that so much in our pain podcast, but why actually keeping going, keeping mobile, keeping hydrated, particularly when you've got newly diagnosed myeloma or you're starting treatment, is so important because it just helps the blood circulate and it helps the blood flow. Although actually lots of patients who might, for example, be starting their first line of treatment, and often that does include lenalidomide, which is one of these tablets which can cause blood clots, they will also be prescribed blood thinners of some sort. But those same rules still apply. Blood thinners do confer a lot of protection, but it's never absolute. So keeping going, keeping hydrated is still very important.
So those risks that you can minimize, or one can hope to minimize without medication, Sally, you said really important things like staying hydrated, trying to keep moving. Now, sometimes, of course, you'll need to use painkillers to minimize that so you can keep moving. So it's another reason why controlling pain is so important. Treating the underlying myeloma. So actually, by controlling the cancer, you are inherently reducing the risk of clots. So those things are all good, Sally. But you touched on blood thinners, and so many of our listeners will have had one of those immunomodulatory agents. How do we decide which blood thinners to use? And is there more than one option? So I think let's talk about prevention first, I think.
Yeah, absolutely. So there are lots of different types of blood thinners. I mean, it wasn't such a long time ago that all we had to play with was warfarin. And thank goodness yeah, exactly.
Yeah.
Thank God that's gone out the window, because that was a bit of a shocker. People were either taking too much or too little, and they could or they couldn't do things which would affect their absorption and how well it worked. It was really difficult. Whereas now there's a repertoire, there's a choice of treatments to give, and we may consider the choice based on lots of factors. For example, how well are their kidneys working? Or what are their other blood counts like? How quickly do we need to switch off the blood thinner if they've got an operation coming up, for example, or something where we need to control the bleeding quite suddenly? But more often than not, actually, I'm sure you're the same as me, Jam. We give tablets now to thin the blood, whereas once we would have given in injections in the tummy or, like I say, warfarin. Now tablets can actually do the job in most people, and that might be most commonly a drug called apixaban. But there's also a drug called edoxaban, or rivaroxaban could also be employed. But I think apixaban tends to be the favourite with myeloma doctors, and I suspect you're the same.
We can normally do it with tablets, and this tablet apixaban given twice a day or similar sorts of agents, really effective at preventing blood clots, but certainly not always. It can be difficult to safely thin blood in certain scenarios if people are at risk of bleeding for other reasons, which, as you said, Sally, can be related to low platelets, which can happen when myeloma becomes more active again, or at diagnosis. Having a low platelet count at diagnosis is a bit rarer. I often get asked, Sally, a lot of our patients are on aspirin for other reasons, a wonder drug in so many ways for so many different sorts of conditions. So they say, no, but I'm on aspirin. Isn't that enough to thin my blood? What's the reason that in lots of situations it isn't enough?
Yeah, well, that's such an important question, isn't it? Because aspirin is really good. It works largely by stopping those little platelets we spoke about from sticking together and making a clot. And it's very frequently prescribed for people who've had heart attacks or strokes, because it can help to really reduce the risk of those heart attacks or strokes again in the future. And also it can calm down any sort of inflammation we spoke about earlier. Thank you for listening to the Myeloma Minutes podcast, proudly partnering with Myeloma UK. For more credible myeloma-related material and support, please visit the Myeloma website at myeloma.org.uk. That's myeloma.org.uk. Or call the info line on 0800 980 3332, which you can find in this episode's description. So it works in one very particular way, whereas the other blood thinners that we use, let's call them blood thinners for the sake of it, apixaban, work on other parts of the pathway, and so therefore are arguably tackling the risk of blood clots from a different perspective. And so often we do need to give the two medications side by side. Sometimes aspirin is enough just in itself if you're particularly low risk. But if you're high risk because you're not so mobile, perhaps you're carrying a bit more weight, you've got kidney failure, you're on lots of steroids, you're on lenalidomide, aspirin just simply isn't going to be strong enough to prevent a blood clot. And I think the studies that have been conducted in the past have proven that point. Yeah,
really important point. Often what people do is, in people who've never had a clot, once their myeloma is much more under control, and say that they're going to stay on a low dose of one of the immunomodulatory agents for a long time, for example, like lenalidomide maintenance, people move from apixaban to aspirin. That's certainly something that I do, regularly in my practice. But certainly at the beginning, with all those risk factors, and often the risk of getting a clot is much higher at diagnosis when you have that high disease burden, the pain, the dehydration, the kidney failure, that of course, not everyone has all of these things. But when you're considering all these factors, the last thing you want is for someone to get a blood clot, which is, typically a deep venous thrombosis, or a part of the clot moves from the leg up towards the lung and causes what we call a pulmonary embolism, which can make people, very breathless and very sick. So that is why we try and prevent where we can. So Sally, if we unfortunately can't prevent it, now we've all met people who actually the first time we meet them, they have a clot. And actually, unfortunately, it's not unusual for some cancers. The first time people find out that they have cancer is because actually they're diagnosed with a blood clot. And I'm sure you've seen that in myeloma clinic. I've seen that in a few patients over the years as well. Very sort of broadly speaking, what do you have to do then if there is already a clot? I mean, you need to make the diagnosis, and that's done specifically with certain types of ultrasound scans of the legs or specific CT scans of the lungs. And it's normally a relatively straightforward diagnosis to make with the right scans. How do you approach thinning the blood then? And what does that mean for actually giving treatment?
Yeah. I mean, again, it's quite complex, isn't it? But to simplify it and give a very straight up answer, you want to give the similar blood thinners, but you just tend to give them at a bigger dose. And you tend to start on a higher dose to begin with. And after a number of weeks or months, you can then go down to a maintenance dose. And what the studies have shown is the clot gradually with time dissolves. Now, we frequently are asked, aren't we, in clinic, well, how do you know it's gone away? Not least actually, because particularly if you've had this blood clot in your leg, the DVT, all these blood clots, again, have these sort of letters to describe them. It's really confusing. But the DVT refers to a deep vein thrombosis, most commonly in the leg. Even when that clot has gone away because you've thinned the blood appropriately, sometimes the leg can stay quite swollen. And so often people say, well, don't you want to check it's gone? Or if it's in the lungs, don't you want to check it's gone away? And we sincerely don't. Very, very, very rarely do we need to. But what is important is then staying on maintenance blood thinners thereafter. And often actually, if it's someone living with myeloma on treatment and they've had a blood clot, that means actually staying on blood clots long term, and that can be for many, many years.
Indeed. So what can sometimes happen is you might get around 6 months of the higher dose of the blood thinning medication, but then go down to the low dose. And as you say, beyond that, perhaps indefinitely. So that's irrespective on whether you're on a drug like lenalidomide or thalidomide. The fact that you've had a clot means that you need to stay on that sort of low dose, often this drug, apixaban, for years and years.
Yeah, the stakes are just quite high, aren't they, Jam? I mean, without sort of overstating this, but particularly blood clots in the leg, even once you've diagnosed it and you've treated it, it can, unfortunately, sometimes cause just long-term swelling of the leg, and sort of that can be uncomfortable for people, and it can, in the worst case scenario, affect mobility. So you don't want that to come back. And similarly, a blood clot in the lung, I mean, the small ones actually in the lungs are the easiest ones to pick up because they hurt. So when you breathe in, it's painful. You feel like a stabbing pain. But sometimes people can get really poorly because the oxygen, the blood just can't flow into the lungs to then pick up the oxygen that the body needs. That can be, as you said earlier, a really important need to diagnose it quickly to get someone more stable situation. And you just don't want to ever take the risk of that coming back again because it could have profound consequences for that person. So it might feel like we're overcooking it. It might feel like, God, do I really need all these tablets forever? But actually, if that is you or your loved one in that situation, talk to your doctors. They'll explain the logic why and perhaps explore any alternatives if they exist.
And I think if you're on blood thinning medication, it's one of those things that you can be on endlessly and sometimes lose sight of why you're on it. So it's one of those things when you go back to clinic, it's like, this is what I'm on for blood thinning. Is it the right thing? Do I still need to be on it? Ask for the rationale, because I think as well, sometimes in clinic as doctors, you can sometimes actually forget, because if the clot was a number of years ago, you're not looking in at the notes. So it's always a good thing to sort of draw into your consultation and say, let's just look at this. Sally, just to sort of, go with that a little bit further, for people who on maintenance, for example, maintenance lenalidomide for years, do they need sometimes anything at all?
No,
because
I mean,
there is a bit of discussion, and I know plenty of people who just actually drop it, actually.
To some extent, the lower dose of apixaban, so that's that tablet you referred to that you take twice a day that thins your blood really nicely. It doesn't really come with many side effects. As long as you're not prone to falling over, you're wobbly on your feet, or you're going to injure yourself and therefore get bigger bruises because your blood's a bit thinner. I think you can continue on it with relatively free from harm. But equally, why carry on with the treatment if you don't actually need it? So when your myeloma is under control, you've never had a blood clot, if those risk factors, some of which we spoke about earlier, aren't present in you, I think it is reasonable to say you can stop it. But if that situation changes and you become immobile or other risk factors creep in, it's always worth reappraising it. So it's quite a dynamic situation. And like I say, it's something which I think goes through a lot of doctors and nurses' minds when we're looking after the myeloma patients.
Yeah, no, indeed. I mean, just to make it clear for the record, for the vast majority of patients, I recommend that they stay on something. Even if it's just aspirin, because as you say, most people are not at excess risk of bleeding. So the kind of risk benefit is very much in their favour to be on something. And this is really one of the areas of medicine, this sort of bleeding and clotting, where you're always dynamically assessing the pros and cons. Is this person in front of me more at risk of bleeding or more at risk of clotting? And you make your decisions on the basis of that. I mean, of course, educated decisions on as much data as you have, and you can get, of course, data from the history, from the scans you do, and there's specialist blood tests that also can sometimes give you a clue about whether someone may be at risk of a clot.
Yeah, definitely. And I think, practice has changed a lot, hasn't it, over the last few decades? I mean, I remember starting as a junior doctor, and almost everybody now who comes into hospital is started on a blood thinner just by virtue of being in hospital. The fact that you're poorly, you're less mobile, you need to have your blood thinned, because the last thing you want is to get a blood clot because you're in a hospital bed. But when I started as a doctor, that didn't happen. And people were popping up with blood clots left, right and centre. And so I think the practice has changed a lot. The drugs have got better. The drugs have got safer, and our understanding has improved. And so, yes, whilst these events do occur, I hope that they are increasingly rare. And where they do occur, be that a blood clot in the lung or in the legs, it's not quite the game-changing event that it used to be. We can diagnose these blood clots sooner, better. We've got more sensitive tests. We've got better treatments, and so on and so forth.
Maybe, Sal, we should just sort of focus on the other side of the equation now and talk about bleeding and myeloma. Bleeding, of course, can happen for any number of reasons. And because we use blood thinning medication so widely, one of the commonest reasons may be of people noticing at least bruising, which I think we all appreciate can be extremely disruptive and unsightly, and can be common, can be more common, especially as I think in older people as well, when the skin and the soft tissues are not quite as good at sort of recovering from even sort of sometimes very mild bits of trauma. So that kind of bleeding, is perhaps not uncommon in a number of our patients. When else can patients with myeloma bleed, and what are the scenarios that we should talk about?
Yeah, I mean, I guess you can get bleeding with, procedures. So if you need to have a line put in, a bone marrow done, that's always going to be a risk of bleeding. Or rather, you will bleed anyway, but it'll just take a bit longer for your bleeding to stop. Sometimes, really importantly, if you're on lots of steroids and your stomach's inflamed, or you're not able to take the indigestion tablets, or you're not on the right dose, there might be some oozing inside your body that you're not necessarily aware of. But I think almost everybody who's on steroids is given medicine to protect their tummy from those side effects, but that can definitely be a distinct possibility. And then, of course, you can get bleeding because your blood counts are low, and particularly if your platelet counts are low. And that can, as you say, be the bruising is spoken about. But if your platelets are really quite low, it might also be things like nosebleeds that, you can't control, or bleeding when you brush your teeth can be problematic. So again, it's something which the medical team tend to be very skilled at, is figuring out where the bleeding or the bruising is, what the cause of it might be, and actually even, is this a platelet problem? Is it a blood thinning problem? Is it a this, that and the other problem? So the medical or the treatment side of it that might also be contributing. In
rare situations as well, people who have high levels of paraproteins, these proteins can actually interfere with some of the proteins that help blood clot. And people can bleed much more and for unusual reasons. But as you control the myeloma and the paraprotein goes down, that risk also improves. You touched on our very clever and esteemed colleagues who are hematologists but experts in blood clotting. And we always lean on these guys if we are struggling to understand the myriad reasons why blood is clotting more than it should, or bleeding, or there's uncertainties around whether to thin the blood and how long for, and interactions with medications. And this is just a big shout out to thank them, because these are some of the most wanted doctors in the hospital. Every single speciality needs hematologist
they are.
with a specialist in blood clotting, and that is one of the main reasons I did not choose that speciality.
Well, they get woken up throughout the night with endless queries from everybody, don't they? It's quite something.
It's just a lot to cover, but it's also very nice to be that wanted. So
Yes.
A big shout out to them. They help us a lot. You know, the last sort of 30 minutes or so, we talked about the different scenarios in which we as myeloma treating doctors need to think about blood clotting too much or bleeding too much. And of course, we are trying to prevent things happening where possible, but we have good mechanisms for, diagnosing and treating the clots if we need to.
Yeah, definitely. And this is one other thing, Jam, actually, I just want to pull in because I think I've been asked this a lot over the years, and that relates to going on holiday. I'm about to go on a plane. Yes, please. Yeah. Tomorrow.
I'm about to go on a plane. Yeah, no, we should talk about the travel advice. I wouldn't follow my travel advice when I go on a plane, but let's not get into that.
Yeah, but of course, I mean, I think it's really quite common knowledge, and it's appropriate common knowledge that if you're sat on a plane, not doing much for hours on a long flight, you naturally
drinking
get
a few gin and tonics.
Few gin and tonics, you get dehydrated because they don't want you using the loo the whole time. And then if you're taking medication, which makes you more prone to blood clots, your risk can go up. So some people buy compression stockings. We haven't really spoken about those. They've sort of gone out of vogue. They're the sort of really like tense, almost like tense socks you used to put below the knee to help squeeze those veins to stop the blood from clotting in them. And you can buy them for plane flights, which can be useful. But the best thing to do is drink loads. Ask for more water, get up and walk around.
Drink loads of water.
Yes.
Drink loads of water. We've got to be very specific. Yeah, drink loads of water.
Yeah, get up, walk around and take your blood thinners. And if you're about to go on a plane flight and you've got myeloma and you're not on blood thinners, have a chat with your doctor about how important it might be. It probably won't be necessary, but it's never a silly question to ask because it is another risk factor. A
really important one. And we know that our patients are going to be taking more and more holidays because of the long remissions that some of our new agents are leading to. So really important point and very good advice to follow.
We've spoken a little bit around, haven't we, the blood clot issue? But get in touch with us, listeners, if you've got any experience or any thoughts on this, and we'd be delighted to hear what you've got to say.
Thanks very much, everyone, for listening, and we'll see you at the next episode. Take care.
All right.
See you, Sally.
Thank you. Cheers. Bye.
Bye. This has been the Myeloma Minutes. We hope you found this week's pod engaging, interesting, and above all, understandable and genuinely useful. If you enjoyed today's episode, please follow the podcast and share it with anyone who might benefit, from your online support group, your medical team, to friends and family. And as always, if you have questions or topics you'd like us to cover in the future episodes, please do get in touch. You can find us at www.themyelomaminutes.com or email us at themyelomaminutes@gmail.com. And you can find us on social media by searching The Myeloma Minutes on Instagram and Facebook. Many thanks for listening, and we'll see you at the next one.